we will start, sir. Yeah, good evening to one and all. On behalf of API and ICP, I heartily welcome one and all for this World Hepatitis Day virtual program. All delegates who have joined virtually from whichever place to learn from the esteemed faculty. I welcome all the office bearers of API Karnataka, Patron Dr. Maya, Chairman Dr. Rajshekhar, Secretary Dr. Vishwanath, Dr. Ravi Kirti and all the API members from all over the country who have joined. I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus RGUHS Bangalore. I also welcome Dr. A. Muruganathan, past Governor ACP India Chapter, who will be joining shortly, and the past Dean ICP and past President of API, and so many other organizations who needs no introduction. I welcome our today's chief guest, Professor Dr. Shyam Sundar, distinguished professor from BHU Varanasi and National API President, a great academician, researcher, scholar, who has taken National API into an internationally recognized association and a prestigious association with innumerable publications, both nationally and internationally, dedicated to academics throughout his career. I welcome our today's speaker, Professor S.K. Sareen, Chief Hepatologist and Vice Chancellor of prestigious Institute of Liver and Biliary Sciences, Delhi, institute known for its academic excellence. Professor Sareen, a great teacher par excellence and teacher of teachers, well-known personality both nationally and internationally, past chairman of Medical Council of India, received many awards, many publications, author of many books. ILBS academic activities conducted are highly educative for training postgraduates and young physicians. Recently certified course in hepatitis was of a great help from the Project Prakash, with many more such courses being conducted regularly, educating all over the country doctors virtually. I also welcome our today's moderator, our own faculty, Dr. Manu Tandon, senior most gastroenterologist and a great teacher and a high valued academician from prestigious Asian Institute of Gastroenterology, Hyderabad, headed by world renowned endoscopist Dr. D. Nageshwar Reddy. I also welcome our today's panelist, Dr. Naresh Bhatt, the chief gastroenterologist from Aster CMA Hospital, Bangalore, the past president of Indian Society of Gastroenterology, a great name in field of gastroenterology, dedicated to academics with many publications to his credit. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service to COVID-19 patients in spite of so many hurdles in the past, anticipating the fourth wave. Let us not waste the time by reading their CV profile, which runs in pages. Let us utilize time by hearing and exchange of knowledge with them in their respective specialty. As I can see, more than 100 delegates who have joined, registered from many states, making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life, that speaks how powerful the faculty is in their specialty. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः शत्रुबुद्धि विनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्नमोस्तुते शुभं कुरुत्वं कल्याणं आरोग्यं धनसम्पदः
We are virtually honoring all our guest faculty for their tremendous contribution to their work done in the respective field in the country. Thank you. Now I request Professor Dr. P.S. Shankar to address the gathering.
Dr. Shyam Sundar, Dr. Sareen, Dr. Muruganathan, Dr. Tandon, Dr. Bhatt, Dr. Maya, Dr. Rajshekhar, Dr. Vishwanath, Ravikirti, Sangram, colleagues and friends. World Hepatitis Day has attracted Professor Sham Sundar from the Holy Land of Varanasi and Dr. Sareen amidst us today. I extend them a cordial welcome. Dr. Muruganathan has domiciled to our state, and I am happy he is with us. Dr. Maya, Rajshekhar, and other faculty are also here. World Hepatitis Day is celebrated to draw attention of the mankind that a person is dying every 30 seconds from a hepatitis-related disease. And we can't wait to act on the viral hepatitis. I can't wait is the theme for the World Hepatitis Day 2022. It has drawn our attention to accelerate our fight against the viral hepatitis. It is necessary to test and treat persons who require it and to prevent its occurrence. World Hepatitis Day is one of the 7 officially mandated global public health days. The day marks the birthday of Nobel Prize winning scientist Dr. Baruch Blumberg, who discovered hepatitis B virus and developed a diagnostic test and vaccine. And the discoverers of the hepatitis C were also honored with the Nobel Prize 2 years ago. In 2018, the World Health Assembly adopted a resolution that viral hepatitis should be eliminated by 2030. The clinical presentation of acute infection may range from asymptomatic subclinical illness to fulminant hepatic failure. We are aware of the 5 types of hepatitis virus A, B, C, D, and E. Most of the acute hepatitis infections are associated with complications which are often fatal. Efforts are made to eliminate hepatitis infection due to B, C, and D hepatitis virus. Unlike acute viral hepatitis, these 3 infections cause chronic hepatitis that lasts for many decades, cirrhosis, and cancer. These 3 types of chronic hepatitis are responsible for 95% of deaths. There are investigations to diagnose these conditions and prevent them. A new form of hepatitis virus infection, referred to as the occult HCV infection, has been recognized. It is characterized by the presence of HCV RNA in the liver in the absence of serologic markers of infection. And this occult infection can present in 2 different clinical situations. In anti-HCV negative serum HCV RNA negative patients with abnormal liver function tests, and in anti-HCV positive subjects with normal value of the liver enzymes without serum HCV RNA. The diagnosis of this occult viral infection is by detection of HCV RNA in the liver cells, and the condition is associated with liver, the necro-inflammatory activity, and the fibrosis. Occult hepatitis C virus infection is a new entity that has to be taken into account for the diagnosis with liver disease of unknown origin. And the World Hepatitis Day is highlighting hepatitis care close to the primary healthcare faculty and to the communities. And I am happy to be associated with the inauguration of this update. I wish the program all success. Thank you.
Thank you, sir, for your kind words of wisdom. Now I request Dr. Muruganathan, sir, to say a few words.
Thank you, Dr. Sangram Brother. As I told you, I am out of station, but still I'm in the car. I know I always appreciate the Sangram, for organizing all national important health days. I think Sangram has already mentioned the message in the Hepatitis Day is prevention is better than cure. Whether it is hepatitis A or hepatitis B, you can prevent it. And if somebody has not taken vaccine, it's high time that they should take the vaccination for against hepatitis B. Today I'm going to have another program also, Love Thy Liver. That was the topic. Liver is such a good organ in our body. It's a good factory, doing so many good things which we cannot even imagine even in the modern days. How liver can do so many enzymes are there, so many metabolisms are happening. Really amazing. the creation by the nature and the God. What are the things there in liver? And liver is one good organ. Even if it is 70% fail, still it is active. Only if it is more than 70%, it shows failure. So I think we must, it's our part to protect the liver. I always say, you talk to the liver, you talk to your organs, and make sure your organs are kept comfortable. So I wish all the delegates a very good, happy, healthy life, and take care of your liver. Tell your colleagues and friends, don't insult liver by taking any substance or alcohol, or any other drugs which will injure liver. So protection is better, prevention is better. I once again congratulate the organizers and all my colleagues. My Syam Sundar, my friend, is there. I wish the function all success. Over to you, Sangram.
Thank you, sir. Thank you very much. Now I request Dr. Rajshekhar, Chairman API Karnataka, to say a few words.
Good evening, one and all. Respected APA President, Dr. Shyam Sundar sir, today's guests of honor, Dr. Shankar sir, Dr. A. Muruganathan, today's the speaker, Dr. Shiv Sarin, moderator, Dr. Manu Tandon, panelist, Dr. Naresh Bhatt. And I would like to, at the outset, I would like to thank our program coordinator, Dr. Sangram Biradar, without whom this function would not have been there. So the importance of World Hepatitis already told by Dr. Shankar, I don't want to repeat, and also by Dr. A. Muruganathan sir. So the theme of We Can't Wait to Act is 2021 actually. So 2022 theme is Bringing Old Hepatitis Care Closer to You, which aims to raise awareness about the need to bring hepatitis care to primary health faculties, community-based venues, and also like hospital sites, so that care is closer to communities and people wherever they are. So that's why the global health sector strategies emphasizes the importance of person-centered care and elimination of this by 2030. So it also emphasizes about the early diagnosis, and also those who are eligible for treatment must be cured. And the 5 actions to protect against, as Dr. Muruganathan said, prevention is better than cure. And we have to follow the 5 actions, the basic things to protect against hepatitis. That is using sterile injections always, using our own razors and blades, practicing safe sex, using safe tattooing and piercing equipment, and most important, vaccination against hepatitis B and hepatitis A. So Sangram Biradar sir, so we are eager to listen to the lectures by our great speaker and moderators.
Thank you. Thank you, Dr. Rajshekhar sir. Now I request our chief guest, Professor Dr. Shyam Sundar, National President API, for your kind address, sir. Over to you.
Thank you, Dr. Biradar. I must congratulate you having organized this program, and esteemed faculties. My greetings to them and the colleagues who are participating in this webinar. I think it is a very important day, and to organize such a program, makes you aware and brings up. If you have a speaker like Dr. Shiv Sarin and others, I think you are updated absolutely to the current practice of this. As you know that hepatitis B is prevalent, prevalence is 1 to 3%. And looking at the size of our population, you can just imagine the numbers that we have. Similarly, hepatitis C infection, also a very large proportion of the patients population are positive for it. So, and high proportion of these persons with hepatitis C infection or hepatitis B infection will develop cirrhosis or hepatocellular carcinoma. And as everybody has must be done at all levels. It is also very important with such, there is a paradigm shift in the treatment of these two hepatitis, and hepatitis C, you can think of it as well. It is important that we mobilize resources. The government provides free treatment for these patients with hepatitis C and B. So I think I once again congratulate Dr. Biradar for having organized this webinar and wish it all the success. Thank you very much.
Thank you, sir. Thank you very much for sparing your valuable time. Now we move on to the scientific session. Now I request Dr. Manu Tandon, sir, to take over for the proceedings. As Dr. Sarin, sir, has already been introduced. Over to you, Dr. Manu Tandon, sir.
Yes, I think, thank you, Dr. Biradar, the entire team, API and the Karnataka, as well as the stalwarts for the privilege of this talk. Dr. Sareen, I had the privilege of being a junior resident when he was at the AIMS during his days of specialization. I don't think anyone else remotely has put India on the map of liver disease as Dr. Sareen has. His work, especially in portal hypertension, is seminal. His classification of viruses is something that we and all the future generations of students of portal hypertension, gastroenterology, and physicians follow. Besides this, excellent work in the therapeutic management of portal hypertension also. As Dr. Biradar has said, the list of achievements of Dr. Sareen would overshadow the time that has been given to him for talking. With these few words, I'd request Dr. Professor Shiv Sareen to start his talk on the subject. Thank you. Professor Shiv, stage please.
Kindly unmute, sir. Unmute, sir.
Thanks to API and ICP Karnataka, I'm indeed very privileged that the President API, Dr. Shyam Sundar, and the very, very eminent Dr. Muruganthan, both are here in this. And of course, excellent inaugural speeches by Dr. Shankar, Dr. Rajshekhar, and I must compliment Dr. Biradar for having invited me and organizing it in a short period. I will try and discuss today something been discussed before. And I want to
Can you raise the volume, sir, little?
I want to bring this to the people for the first time. This is a very new topic I have prepared, and it's very controversial. But I want to bring it to your attendance for Hepatitis Day today. And I'll come to it in a minute's time. Yes. Can you see my slide, please?
Yes, we can see the lead slide. Dr. Sareen, we can see the building anyway. There.
Is the slide okay now?
Yeah.
Yes, the slide is okay.
Okay. So the topic today is treat, select, or treat all. And the topic itself brings the question, do you want to eliminate hepatitis B or you just want to treat hepatitis B? I have no conflict of interest. And my outline is what is the current policy of treating hepatitis B and why? And do we need to treat all? And I'm sure Dr. Manu Tandon, one of the finest products of All India Institute, would also like to give his comments. And Dr. Naresh Bhatt, one of the senior most gastroenterologists, would also like to comment on need for treat all. Let's go further. Basics. Hepatitis B is a DNA virus, and it has on the surface of the DNA a protein called surface antigen. Hepatitis B surface antigen positive means the person is infected and he is replicating. E antigen is a marker of high degree of replication. Anti-E is a low replication and a mutant virus. Please remember it. 70% of India is anti-E positive, E negative. IgG anti-core. This is the core. Anti-core is a masked exposure. 30% of India, 30% is IgG anti-core positive. If you have a bone marrow transplant, renal transplant, or any other immune compromise, please get it tested. Your marker of protection is anti-HBs, which should be more than 10, preferably more than 100. And marker of injury to the liver is AST or ALT or SGPT. Hepatitis B comes from blood and infects all hepatocytes, all. Against these infected HBV, there is a cytotoxic lymphocyte, which is CD8, and it kills these cells. By killing these cells through interferon pathways, cells must die. Every cell must die. And then you eliminate this. So hepatitis B is eliminated when you have a very strong CD8 response specific to hepatitis B. Now, in chronic infection, the CD8s are not there. Virus is present. Instead of CD8, you have a CD4, which is T regulatory cells, which inhibits the, or you have NK or NKT cells. So the virus persists. So how do you get rid of the virus from body? Convert chronic to acute. If you make this into a, you will clear the virus. So the theory of clearing the virus is when you have high ALT, 200, 500, 1000, you will clear the virus. Higher the ALT, lower is the DNA, as in acute hepatitis. In fulminant hepatitis, no DNA in blood, only dead cells. So the way we treat is chronic is converted to acute by interferon or by spontaneous seroreactivation. This is the theory for last 40 years. We'll have to move further. We cannot achieve it. So what can we achieve today? You can suppress the virus, make it undetectable. You have very important drugs, tenofovir, TAF, and entecavir. You can make the DNA negative. You can make the surface antigen undetectable. This is called functional or clinical cure. If we can achieve it, we may not be able to lose hepatitis B surface antigen. It is not seroconversion. Then we are okay. Of course, absolute cure, I'm not discussing at all. What are the barriers? Why can't we achieve it? Because if there is a lot of virus present, your CD8 is exhausted. No CD8. If you have weak CD8 and lot of natural killer, it's pointless. And you have more of inhibitory proteins like programmed death receptor PD1 or CTLA4. These are inhibitory markers. If you remove PD1, CTLA4, NK cells, give CD8, you will get the virus cleared. Now, there are several phases. This is a phase of a person who has high DNA and normal ALT. What happens in such a situation? You say, अरे भाई ये तो carrier है, इसका तो कुछ भी नहीं है, इसका तो ALT normal है. But in such a person, DNA actually goes up and down, and ALT goes up and down, Let's now take a person who is born to a mother who is positive. Now you start seeing the journey. Newborn, 0 day. If he gets the virus from the mother, he will have chronic infection in 90%. High level of DNA, normal ALT for 20 years. And then there is slowly a decrease in DNA and ALT. This is when you see him 20, 30 years. And then again reactivation. Let's go further. If somebody gets through blood transfusion, needle stick, 95% adults clear, less than 5% will have hepatitis B. These ALT flares, whether in the children who grow up or otherwise, cause liver injury. Now, initially he was E positive. Please pay attention. He remains E positive. Body wants to clear the virus, but body fails every time. In a small proportion, body can convert into E minus. In India, fortunately, 80% of the virus is E minus. They will reactivate over a period of time. Some of them, 0.5% will clear, but remaining people will continue to have the virus. So what we are looking at, two scenarios. One is an E positive. Here is E positive, E positive. Here it is immune tolerant, no immune activity. Normal ALT. This is immune tolerant. Here it is immune active. Body is trying to clear, but gets chronic hepatitis. Here there is almost silence and again reactivation, but this time E minus. What is our ideal endpoint? Loss of surface antigen, which is not easy, but you can suppress it. A satisfactory endpoint, functional, is clinical, is normal ALT and DNA negative. How does hepatitis B come in India? Blood banks are very good, no more, probably rarely 0.01 or 1.1%. Otherwise, today, all hepatitis B is mother-baby. So what we did was we tested children, 10, 12 years, 116 of them, tested their mothers. Mothers had, 3/4 of the mothers had one marker. And this, if I can give you this message, it is actually the crux. The mother is HBsAg, but she is negative, only 15% mothers. What will mother have? Anti-E, marker of sometimes replicating virus. Past exposure, anti-core or anti-HBs. So if the mother who was never vaccinated is anti-HBs positive, means the mother had hepatitis B. But she has cleared it. So check in the mother all four, not one, all four markers. Also check in the brothers, sisters, and spouses. So today in India, in my opinion, this is an old study, 95% of the hepatitis B is mother-baby. Now, how are we treating? Today, the guidelines clearly say all cirrhosis or reactivation, the flares, or fibrosis is F2 or more, and inflammation, high ALT. And the ALT is 2 times or more, or DNA is 4 log, 20,000 or more copies, or patient is E antigen positive. But if is E negative, low replication, 2,000 units. All guidelines, American, Asian, say this. The basis of treating hepatitis B, and I hope it makes good sense to you, remember 3 things. Stage of fibrosis. Bhai, bimari hai, kya grade ka bimari? How much is the virus? And how much is surface antigen? So let me clarify, if you have 1 copy of the virus, surface antigen is about 10,000 times more. So this is a marker of replication of CCC DNA in the nucleus. It's a quantitative HBsAg is a more sensitive marker. Third is inflammation or ALT. 3 are major scenarios, and we can have different scenarios. I'll come to them. So the current guidelines is whom to treat. DNA is high, ALT is high, treat. First is interferon, then nucleoside analog. Very, very effective in this. Now, ALT is not very high, but DNA is high. Such patients need to be seen, and then maybe interferon or maybe oral drugs. The problem comes in the group where there is low DNA, moderate DNA, and ALT is raised or not raised. In all these patients, one single thing is fibrosis assessment. If the fibrosis liver stiffness is more than 8, or liver biopsy shows stage 2 fibrosis or more, treat. But these are old guidelines. We have to go beyond it. You will see that If the DNA is less than 2000, let's go it, less than 2000, but there is no fibrosis, low fibrosis, he is not treated. Patient is E positive, but ALT is normal. Patient is E antigen positive, but ALT is normal. Here, there is a person who has a normal ALT, he will not be treated. It is immune tolerant, even if the DNA is high. See this? High DNA, but ALT has to be above. Third, no fibrosis significant in any group, he will not be treated. And lastly, if there is no family history of HCC, he will not. Only 30% of the people come in guidelines, 70% are outside the guideline. So now the big issue and the talk, do we need to treat all? And if so, for how long, and should we treat them? Long-term nucleoside analogs, entecavir, tenofovir, TAF are desirable. You can see in this study, people who were treated versus those who were not treated, the incidence of liver cancer is different. It is lower if you treat them. Can you prevent ascites, jaundice? Yes. If you give lamivudine compared to placebo for 3 years period, you can see the decompensation from about 19% comes to about 7% or so. Huge advantage. No more liver disease worsening. Should we treat them early? You can see that from HIV ART therapy studies, if you give early treatment versus defer it for some time, ART, there is a significant advantage if you start early. So why not in hepatitis B? Here you see 4 categories of people with DNA. Here the DNA is undetectable. Here the DNA is raised. Here it is in the beginning low. And here is a person on antiviral therapy. If the DNA is undetectable, you can see the incidence of liver cancer is just about 2% or so. But if his DNA, let's say less than 2000, you will not treat him. Over a period of 5 years, he may have 12% incidence of developing liver cancer. Do you want your patients to have liver cancer? Just because the guidelines say less than 2000, we don't want to treat. Let's go further. They say normal ALT drugs will not work because there is no CD8. You can see that if there is normal ALT, even then, if the patients are without antiviral therapy, there is a high risk of developing liver cancer. Detectable versus undetectable, a high risk of patients in multivariate to have liver cancer. So DNA, if it is undetectable, you are safe, irrespective of ALT. I hope I'm trying to drive home this point that ALT is not a good marker of inflammation. Don't bother about it. And DNA, if it is undetectable, it is better. But what I'm talking is beyond guidelines. If you give early antiviral, what will happen? This Lancet study, I'll show in a minute, fibrosis, cirrhosis can regress. Here you will see that in this group, the people who have got stage Ishaq 6 means cirrhosis was so many. After 5 years, this percentage has decreased. Or you can say stage 5 has almost disappeared. On the other hand, lower stage of fibrosis, regression of fibrosis has occurred. Will you treat all immune tolerant? Means all normal ALT should we treat or not? The message is higher ALT, greater immunity, it is better. But let me show you some data. This is a study very important, first of its kind, done by us. Manoj is the lead author. He was a fellow at that time. F0, F1, F2 fibrosis, F3 or F4. Now, these are groups of patients who for 12 months have normal ALT. Normal ALT means no disease, no inflammation. We did biopsy in each one of them. You can see 25%, 26% almost had F2, 11% had F3, and 3.7 F4. Total about 40% of the patients had significant fibrosis. Another study from Korea, even in them, about 20% had significant fibrosis. But they have normal ALT. So ALT normal does not exclude a patient for getting treated. Should we lower our threshold for treatment? Yes. Now, here is group of again DNA. People are E antigen negative, means low replicative state. They have less amount of development of chronic hepatitis. Those have higher DNA, less than 10 raised to power 4, may not have normal ALT or normal ALT have higher chance. But those who are E positive but normal ALT have maximum chance of developing chronic hepatitis. According to the age, now here you are seeing people who are 20 to 29, 30 to 39 and others. As you would see, if there is an elderly person, he has a much higher chance of developing clinical complications like maybe ascites, jaundice. And most of these people are harboring the virus from the mother. So 60-year means the virus is also 60-year-old. In 60 years, it will cause disease. And the DNA level at baseline, the lower the better. But if you have DNA, which is 3 to 4 logs, certainly the problems will increase. This is another very important slide. You say, this guy has normal DNA, low DNA, and he has got normal ALT, SGPT. What happens to them over 5 years' time? Those who had a DNA of less than 100, even in them, 9% will have a problem. They will have one or the other clinical event. Those who have DNA around 2000, 24% will change. They will increase their DNA. So what it means is almost 1 in 4 E negative will flare in 5 years' time. And a flare means injury, high risk of integration, liver cancer. In this study, the incidence of liver cancer, death or transplantation. One is immune active, means SGPT going up or down. One is immune tolerant, always normal ALT. But they are not treated, they are treated. Why they were not treated? No guideline allows them to treat. The liver cancer, death or transplant is almost double or triple, even with normal ALT, but if you don't treat. Very convincing data that we must treat all. There is a new concept of hepatitis B integration and clonal hepatocytes. A person who is, I'll not go into details, who is immune tolerant, means normal ALT, E antigen positive, high DNA. If you withhold antiviral, it is not correct because they form clones of hepatocyte which will become HCC over a period of time. So the recent review says and challenges the notion that immune tolerant phase is benign and we therefore should not treat them. It carries the risk of cirrhosis, liver cancer, premature deaths world over. So early treatment then recommended by current guidelines should be changed. Now, will you treat all patients with minimally elevated ALT is just 45, 50? The current say in ASLD, American guideline, don't treat if it is less than 70. But his ALT is, let's say 52, 45, you will not get a treatment unless you have stage 2 fibrosis. Apostle up to 80, no therapy, unless you have stage 2 fibrosis or liver cancer in fact. EASL has in 2018 come out that yes, if it is between 41, EASL is European Association, 41 and 80, you will treat. But again, F2 fibrosis. So what I want to say is you are finding patients eligible for therapy, but you don't do it in other diseases. Let's say you give tenofovir versus placebo. In tenofovir was given long period and here placebo. Fibrosis stage almost double in placebo compared to tenofovir and cirrhosis almost 4 times more. Patients with minimally elevated ALT, if you give them tenofovir compared to placebo, you are able to bring down the fibrosis, like stage 6 come down, stage 5 comes, and other stages come down. Progression of fibrosis is decreased when you give tenofovir, no progression compared to placebo, almost double progress. If you have minimal elevated ALT, viral suppression is far better than doing. So you are able to suppress the virus for 3 years with tenofovir, 81% of the ALT is normalized in 80%. People used to say these drugs are effective in normal ALT, but these drugs are very effective and you can achieve viral suppression and ALT normalization. 1 or 2 more slides. Now a new term of metabolic dysfunctionated fatty liver disease, earlier NAFLD. If you have a patient with MAFLD and who have, and India, 30% have MAFLD. Let's look at what. If someone who has more than 5% or 5% fat in the liver and has hepatitis B, the liver cancer nearly 2.5 times more. Here you would have in 10 years just about 4 to 5%. Here you will have 20% or so. So an obese with hepatitis B has a higher risk of liver cancer. No alcohol, only obesity. And if you treat an obese NAFLD with antiviral, his response is same as a normal person. It is sometimes believed that low virological response occurs in immune tolerant. But I show the response is almost same in these groups of patients. Our aim is that we should have HbSAg loss, zero clearance. Zero clearance occurs very, very small percentage. It's about 20,000 treated. But we can achieve complete viral suppression in about 86%. If you achieve complete viral suppression, you have a lower risk of cancer, just about 5.6. But if you don't achieve, then you have about 7.8%. We still have miles to go. These are all patients who were started therapy much later. Maybe if you start 10 years of age, maybe you will never have liver cancers due to hepatitis B. But the bottom line is, if you are able to suppress virus, you can decrease HCC development. Treat all is okay, but how long? In my opinion, lifelong. Here is a very important study which shows you about 400,000 patients coming for health insurance in Korea. Of them, only about 23% were compliant. If you do not, and that's a national free testing, those who are compliant, their liver cancer was reduced by 44%. They were not treated, all of them. I'm not showing you details, but compliance. But suppose who has hepatitis B and he doesn't come for follow-up, you can imagine liver cancer. There is one is non-compliant, one is compliant. Now, those compliant in them, if you are treating them, it is much, much more benefit than not treating them. 8% number. Let's go further. Now the question is, doctor, for how long should I have pills? I don't have answers. Maybe 20 or 50 years from now, we will be able to give you an answer. In my opinion, everyone should be treated, because if you treat them, they will adhere. Of course, there is a cost to it. It's about $30, 2,500 rupees per year for the patient. But these are safe drugs, and I think they should be given. We have started a large trial, and I want you to engage in this trial. Early initiation of TAF to prevent disease progression in cirrhotic chronic HB with normal ALT and low viral. We aim that we will find out in these patients a method of treating. Our hypothesis is early initiation of antiviral therapy with no significant fibrosis. Above 8, of course, you will get treated. It is lower than 8. And the DNA is also lower than 2000. These people will do much better compared to those who are on placebo. So 25 milligram of TAF or no treatment unless they get into a flare. So treat all, we will eliminate hepatitis B. Why? First, stop using the term inactive carrier. It is chronic HBV which flares up and down, occurs in them. In 2000, HIV consortium said treat all. Every HIV patient is treated. There is no virus. These guys are healthy, as happy as anybody. Hepatitis C earlier, the drugs were very expensive. Only F3, F4, then came F2. Now treat all. 2018, everybody is being treated. So you will eliminate. All positive patients will disappear. Hepatitis B, I hope if we all, with the help of API and wise clinicians, we start a campaign globally. This is the first such concerted presentation. In next 3 years, if we can move, we will eliminate all positive hepatitis B. They'll all be virus negative. If they are virus negative, they will not transmit to spouses. They will not transmit to children. So we need only 2 things: treat all, vaccinate all, and we will be happy. There is no more hepatitis B in India. Thank you for your kind attention.
Kindly unmute, sir. Manu Tandon, kindly unmute. Dr. Manu Tandon, kindly unmute.
Yeah. I'm unmuted. Thank you, Dr. Sareen. As usual, you will all agree with me that he's a wonderful teacher besides being an excellent clinician and research worker. You see that over the duration of the last half an hour, he has taken us from the old guidelines, something which I'm sure Naresh also, when we were studying, we had definite guidelines and indications for treating, to the present concept that there is nothing like it is a quiescent phase, it will come up. Based on evidence-based medicine, he has shown that ALT and even DNA levels is better treatment, because long-term follow-up of these have shown that in the long term, development of HCC as well as development of chronic is much higher. So, Dr. Sareen, thank you very much for changing our concept. I think today we are coming to a stage that what you say, treat everyone and treat for infinite periods. The drug is very safe. With these few comments, Naresh is an expert. He heads a large tertiary unit in Bangalore. Naresh, what are the issues you face in hepatitis B patients coming to you?
Yeah,
Your comments, as well as your comment on the new concept that Dr. Sareen has just told us, something that, let us say, at least when we are taught till very recently, we were totally unaware of.
thanks, Manu, and thanks, Shiv, for that lovely talk. At the outset, let's say what we're doing well. Our vaccination strategy is in place, and I think we're doing reasonably well. We have our blood donors are effectively screened, and so we have cut down the transmission rates there. So I think that those are two areas that I think India is doing reasonably well. And as Shiv rightly said, bulk of our transmission is now in neonatal and early infancy. That is where we stand. What are the challenges? Now, the two areas or three areas that I find challenges are in pregnancy. Most obstetricians, somehow there is a knowledge deficit, and there are a lot of strange kind of recommendations that come out from them, which I think interferes in the management of hepatitis B. Either the therapy is stopped, or they ask them to abort the child, and so on and so forth. And I think we need to focus, as physicians, we need to focus on better education of our obstetric colleagues. The second area I think that we are making a lot of mistakes is the concept of flare in hepatitis B, especially in patients who are on immunosuppressions and chemotherapy. Almost universally, we find none of them screened for hepatitis B, and we lose a significant number of patients who are on chemotherapy or immunosuppression because of flare of hepatitis B, which is easily preventable. So this sort of onus is on our oncologists, rheumatologists, nephrologists, and so on. Now, coming to this concept of a functional cure, there are two issues that are important functional cure. One is that we need good access to quantification of surface antigen, and I find that still a challenge across the country. There may be few centers who have that well standardized, but for most of us, I don't think we have well standardized thing, and I would like Shiv to comment on it. The other is the non-availability of FibroScan, again widespread. As a tertiary care center, we have it and we use it as per whatever recommendations. So those are again two challenges as per the current guidelines. Now, Shiv has sort of convinced us that we need to look beyond and look for more kind of universal treatment for hepatitis B. And I'm sure that's a very, very exciting concept. The question is, are the other drugs other than tenofovir or TAF, like entecavir, is it as good in these patients who are normal ALT and low DNA? Does it do the same job, or do we have to stick to this? And why? I mean, it's great as a concept. Why is the reluctance to put it in the guidelines? Because I'm sure Shiv is part of a lot of guidelines and groups. So where is the gap?
Dr. Sareen, your comments, then we'll take some questions from the chat box, because a couple of delegates have asked also similar questions.
Thank you, Manu, and thank you, Naresh. Very, very pertinent points. Pregnancy and the limited, dialogue with the gynecologist. Current guidelines say start antiviral in the 3rd trimester. But I want to clear, and for 15 or maybe 20 years, we have been working on this concept that during pregnancy, the baby is exposed for more than 6 months to the virus. From mother's blood, it goes to the baby's blood and to the liver. And 6 months pass by in the womb. By the time the baby is born, the baby's immune system accepts hepatitis B as its own. So the body cannot clear hepatitis B. And we have a couple of seminal papers in this. So in my mind, the transmission is intrauterine. It is not perinatal. Now, what people are in gynae doing, they are giving third trimester antivirals, especially tenofovir. It decreases, but does not eliminate the risk of still carrying occult hepatitis B in the baby. And there are a couple of New England and other papers on that. So in my opinion, the antiviral can be started safely in first trimester. These are not guidelines. Second trimester, they are coming down from third to second. But in my opinion, and I do it in my clinical practice, after explaining the person, the mother, that this is the benefit. Zero transmission. The virus is totally gone. And we can certainly have dialogues with gynecologists, at least treat in second and third, if not the first. Next is availability of quantitative HbSAg. I agree. It's not good. Both the Roche and the other company, both of them have difficult testing. They have to be diluted and it needs to be standardized. But yes, if you have it, it is good. Fibroscan, I think, is expensive and not easy. But what everyone can do is a FIB4. A FIB4 is your AST, ALT platelet in age. And you have a calculator. And if the FIB4 is above 1.3 or 1.34, it is something to concern. Or if it is above 3.6, certainly it is cirrhosis. So all of us now, our residents will also write FIB4 on the calculation and write it. So fibro is good, but no guideline has adopted FIB4 as of now, except some for NASH. The third is Anteca versus Tenofo. Both are equally good. But Anteca cannot be given in pregnancy, as you know well, but Tenofo can be given. Tenofo has a disadvantage of renal or somewhat bone loss. So TAF is a shade better, but TAF is a little more expensive. Tenofo is good, and Anteca is equally good.
Thank you, Dr. Sareen. You have actually answered the two questions. The first question was how long. You have very clearly said it's infinite. 2074, if we are around, hopefully we'll get a guideline. The second one was both in pregnancy, both were, would you like to put in any guidelines? As far as treatment, you have clearly said better to start first trimester. Can we put any guidelines for pregnancy? Same way what Naresh said, to educate our obstetric colleagues as well as the public in general. One, and I'll put the other question also. One, Dr. Chandrakala has asked that suppose the viral load becomes zero or non-detectable, can we take the chance and stop therapy?
A brilliant question. But first, about pregnancy, it must be mandated. Every pregnant woman must be tested. And the positivity in pregnant women, we have done close to 100,000, 120,000 pregnant women from Lady Harding over last several years. And these pregnancy earlier used to be about 3%, has now come to 1.7, 1.5%. But that's huge. If you have 1 lakh pregnant mothers and 1,500 are positive, you are transmitting. And in India has 26 million deliveries, I guess, every year. And if in 26 million, you have 1%, you can imagine 260,000 new hepatitis B infections every year. So it is important that every pregnant woman is tested. And if positive, there must be dialogue and should be treated. And the newborn should get a vaccine, preferably within 4 to 6 hours, the first dose. 0, then you have a 6-week, 10-week, and 14. 4 doses. Birth dose is a must. If you have H big, you can add H big because very expensive. So in my opinion, and we have shown in our studies, it doesn't make much difference. I would rather give a pregnant woman tenofovir, which is cheap, and get success. The second part is, if the DNA is negative, can you stop antiviral? Well, if you are an expert, here are the guidelines. If the person is E minus and has DNA negative for 3 years and is ALT normal, means his SGPT or ALT is 30, 20 or so, and DNA is negative for 3 years, you can take a chance. You can stop therapy. But this cannot be done in a patient who is cirrhosis or who has got advanced fibrosis. So make sure your patient, if you want to stop, his F0, F1, and his LS, the liver stiffness is less than 8. Don't experiment. Every other day, at least 1 or 2 patients a week we are getting, whom the clinicians, wise clinicians, have somehow stopped or patient misunderstood, and they come with a flare or they come with a tumor. So don't do it. Never in cirrhosis you can stop. Now comes E positive patient. The E positive or a wild type virus, you can stop after seroconversion. E positive has become E negative, which happens in about 10 to 20% per year. And at the end of 5 years, you may have 40%, 50% E seroconversion. So if E seroconversion has occurred and it has remained so for almost 12 months and DNA is negative and ALT is normal and there is a fibroscan which is less than 8, you may try and stop it. But I will never stop an E positive seroconverted because I know where the seroconversion is occurring. At a given time in hepatitis B, there are 20 types of viruses which are there. We call them quasi species. Jैसे Talibani, Afghani, Pakistani, sab aap mila lo. You have different types of populations of virus. E positive is one type of population of virus. You suppress it, it will be negative. And then only E negative is shown. When you stop it, they again jump up. So don't try an experiment in E positive seno-converted stopping. This is my experience. But E negative, always with normal ALT and DNA negative for 3 years with no low fibrosis, you can try under monitoring.
I have a question, Dr. Sareen. Since we are talking of, with so many advances, is there any drug which is targeting cccDNA so that replication stops totally? Anything on the drawing board or phase 1, phase 2?
Yes, very, very good question. Now, triple therapies for hepatitis B are coming. They are by J&J, Johnson & Johnson. So one of their drugs prevents the cccDNA formation. The second delivery product that they have is that RNA, the original RNA from the cccDNA, which comes into the cytoplasm, is stopped. Third is their encapsulation blocker. So all these 3 drugs put together, one is cccDNA, one is mRNA inhibitor, and third is encapsulation blocker. The virus can decrease something like in 24 weeks, significant reduction. End of a year, you can achieve almost undetectable virus and cccDNA levels go down. These are very exciting times. Like for hepatitis C, maybe in 5 years, combinations at different points can come. Entry inhibitor, CCC, DNA inhibitors, assembly inhibitors, and capsidation. They all are in pipeline.
You, Dr. Sangram, would like anyone of other panelists, Dr. Shyam Sundar, Dr. Rajshekhar, ask any queries from Dr. Sareen, please.
I think there are no queries, sir.
Then you should tell
everything
us regarding the time. Otherwise, we can hand it back to
since,
you.
yeah,
Manu,
we will
can I-
wind up.
Yeah, yeah. Naresh has a comment. We'll hand it over to you after Naresh.
Shiv, I wanted you to comment on this in chemotherapy. Do you perceive that as a big problem? And what should be the message that should go down?
Thank you again for raising something which every physician must know. For every patient, like it's an HIV patient, or it is a patient who is a cancer, if you are going, or blood cancers, if you are going to start chemotherapy, please do anti-core, total anti-core, not HBsAg. HBsAg positive, certainly you will give antiviral. But if anti-core is positive, even that patient must be given antiviral therapy, or you will end up with flare in about 5 to 10%. So we must test both anti-core and HBsAg. Anti-HBs has very limited role.
Thank you. Thank you, Dr. Sareen, for clarifying many of our doubts. Thank you, Naresh. I'll hand it over to Dr. Biradar. Dr. Biradar, please.
Yeah, before we close, we will have a take-home message, sir, from each. So I request one key takeaway from your side.
From Dr. Sareen's side first, then
Well,
yes.
my message is in the title. From treat select, try to move to treat all. Of course, use your wisdom, but test all family members and also vaccinate all. But family members definitely do all 4 tests. Mother, do all the 4 tests, and you will save many, many unnoticed patients. And thank you for this World Hepatitis Day. I think Dr. Sangram needs special thanks, because in a very short period he could arrange and also get the galaxy of experts from API and also my own community. Thank you very much.
Yeah. I think there's really nothing more to add, Doctor. It has been a radical change. What I would just add is this message should percolate beyond gastroenterology to all specialties. If you have HBsAg, treat all, treat all. So my message is the same message spread down to every specialty, so that whenever they do come across one, like for HIV, we do the same for HBV. Naresh, you.
Yeah, just the thing is that if you find HBsAg positive, don't brush it under the carpet. Evaluate them further, stratify which set they come to, and then devise an adequate strategy for them. I think that's important. And if you start on one of these drugs, ensure that they continue it, because there's nothing worse than starting it and stopping, because then there's a risk of a flare, which can be worse than what we started off.
Yes,
back
sir,
to you, Dr. Biradar. Yeah, back to you.
Yeah. That was a wonderful discussion, sir. So before we close, I request our secretary to propose the vote of thanks. Dr. Vishwanath, please.
Yes, sir. Thank you, sir. Thank you all, and my special thanks to our speaker, Dr. Sareen, sir. And we all know how once we visit ILBS, we'll realize how lucky we are to have him here today in this API function. And of course, thank you, sir, for sharing your wisdom. And of course, you have a very elegant way of explaining things. My special thanks to Dr. Manu Tandon and Dr. Naresh Bhatt. Sir, both of you, we keep often seeing in our MERT program. So I think the same zeal, enthusiasm we were taught. Now I think in continuation, and Dr. Naresh sir, as usual, to the point, very specific one. I thank you immensely for participating in this World Hepatitis Day being organized by our API and ICP chapters. My special thanks to our guest, chief guest, Dr. Shamsundar sir. I think we had all witnessed his entrepreneurship and the way he manages in a recently concluded Epicon. So I think it was indeed a pleasure to have him also in this meet. My special thanks, to the guest of honor, P.S. Shankar, Dr. P.S. Shankar sir, and Dr. Muruganathan. And of course, our very dynamic chairman, Dr. H.K. Rajshekar, who is really doing wonderful job. And of course, I think I should reserve the best prizes to Dr. Sangram Biradar. As Dr. Sarin said, he deserves a lot of accolades, bringing in all these luminaries at such a short time. I was wondering, I was really surprised when he sent me that brochure, seeing the names. Thank you, sir. And I thank all the members who have joined in this. In between, we had some disconnect, but overall, it was a very good talk. Thank you all. Thank you once again.
Thank you, sir. Thank you. Thank you, one and all, for being with us. Thank you, sir. Good night. Take care. Thank you.
Good night.
You